Glad to have you join us again on another edition of the program, Focus Live, right here on OGTV, the People's Daily. Focus is a no-holds-barred discussion program where we bear our minds on issues affecting us in the society. If there are problems, we provide solutions to them. If there are good things, really, we lend our voices, and of course we commend them. Today we are going to be looking at something that is very, very important really to us in the society. But before I go into that, let me tell you, I'm Dominic Agbea, and of course it's glad really to come your way again and of course bring you another edition of the program. Now, health they say is wealth, and really for many taking money out of their pockets really to food medical expenses can really be difficult for them, and that's why the state government has come up with what it's tagged Imiradero health insurance scheme. Yes, an health insurance scheme that is designed to really help people cater for their medical needs. As a matter of fact, it's like you are putting something on a monthly basis, and then by the time you now need the health service or you need health care or the need for it comes up, you can access the health care service. That's what the Imiradero health insurance scheme of the Ogun State government is all about. So on the program today, we are going to be shedding more light on this. We are going to be looking at how acceptable really it has been, the coverage, what it is like, and other sundry issues. I have in the studio with me my guest, who together we are going to be taking a look at today. He is the Executive Secretary of the Health Insurance Agency, Dr. Afolabi Doso. It's a pleasure having you join the conversation this afternoon.
Good afternoon, Dominic, and good afternoon to our viewers.
Yes, let us begin by looking at the core mandate really of the Ogun State Health Insurance Agency. That's OCHA, am I correct? OCHA. Now, let us, what's the core mandate really, and how would you describe the journey so far?
Okay, thank you very much. Two questions in one. Beautiful questions. What is the core mandate of Ogun State Health Insurance Agency, which we popularly call OCHA? That's our acronym. Our core mandate is to make sure that every resident in Ogun State is covered by one form of health insurance coverage or the other. Every resident, wherever you are, whatever your status, whatever your position, whatever your educational background, whatever your sex, should be covered with at least a basic health insurance coverage. I'm saying so because there are different forms of health insurance schemes. There's the public, the private. Even among the private, there are different ones. But the agency is supposed to be in charge of coordinating everything in the health insurance space. So that's their mandate. So simply put, I'll be happy the day every single member or resident of Ogun State, about 7 million plus, have one form of health insurance or the other commanded. What has been the journey so far? The Ogun State Health Insurance was created by law by the last administration, towards the twilight of the administration. And the present administration came in and really pumping money to make us where we are today. And this is in collaboration with the federal government. Now, I just want to correct one little bit misconception. One of those core mandates is also supposed to run different health schemes. So Imiradero is just one of them. Oh, okay. Imiradero is also one of those schemes. Oh, okay. But generally speaking, we have three different types of schemes. We have the formal sector scheme, the informal sector scheme, and the vulnerable group schemes. Most of the ones you will hear about are the ones for the vulnerable people. Those that cannot pay, those that have problem accessing health, those that are in hard-to-reach areas. So, Imiradero, for example, is specifically targeted for pregnant women. So, Imiradero is for people in those communities who cannot afford to pay a premium. But the journey so far is that we've launched all these different kind of schemes. The formal sector scheme is running, the informal sector scheme is running, and our different vulnerable schemes are running.
Now, when taking a look at or evaluating health insurance programs like this, one factor is very, very core, is very important, and that is the numbers. So, can you give us an idea of, how acceptable really as this in this?
Definitely. When we started in 2019, we did a survey, which we wanted to make sure that it's going to be a baseline survey that we refer to in the past. And the knowledge of people about health insurance was about 11%. Out of the maybe 6,000-7,000 people that were surveyed in all local governments, only 11% know about it. Recently, about 3, 4, 5 months ago, we did another small survey, not as big as that one. And we discovered that, the knowledge about insurance is about 60-70%. But when we now talk about coverage, we are still about 66% of the population of Ogun State. That is if we assume that our population is about 7 million. And so when we break it down in terms of figures, we've enrolled people in the formal sector, we've enrolled people in the formal sector, we've enrolled the vulnerable group people. When we bring everything together, we might say that we probably around 300,000-400,000 people in the state, which is still a drop in the ocean. But it's not the easy convincing people that you should contribute money and put it somewhere for the remaining days of when you fall sick. There are a lot of factors mitigating against it. Religion, culture, and so on and so forth. And this, what if I don't fall sick, what happens to my money? So a lot of the people will tell you, in the name of culture and religion. Well, of course, we get that a lot. We've seen people saying it is that attitude of contributing money that will even invite the sickness to come. So that happens.
So can we also take a look at the EBIDO, for instance, which you said is a core arm really of the whole insurance program. Let's look at how effective really has this been, particularly how it has been able to address
what it was meant to address.
The child, maternal mortality, because we have it on the high side in Africa.
Not even Africa. What happened was that about 5 years ago, let's say before 5 years ago, Ogun State usually has one of the best indices in the Southwest and in Nigeria. Of course, the indices are poor. So when, for example, they say the maternal mortality rate in the state, in the country is about 800 per 100,000, maybe the state is not around 200 or 300. So usually we're better than the national average. But we don't know what happened. About 5-6 years ago, everything just went the opposite side. And we now started getting surveys that says Ogun State has the worst maternal mortality rate even in the Southwest. And of course, his excellence in his wisdom called us and said we just have to find something to do to it. And everybody wants brainstorming. And the best initiative that we came up with is the fact that, well, it's the pregnant women that are dying that are contributing to the bad or worse maternal mortality rate. Because that's what it means. The woman gets pregnant and she dies during that period of pregnancy or during that. So that's the key. Let's do insurance to the poor ones, not those that can afford the third. Let's do the insurance to those poor ones. And that video was not specifically targeted to them. And what it does is that government pays for them. From the moment that they are pregnant, they are able to prove that they are poor. We give them the insurance card free. From that moment till 12 weeks after they deliver, they are on insurance. We take care of all their health needs. Even if the person is down or hypertensive, has malaria, has every other thing, the card still covers during that period. The card covers in the period of delivery, even up to assisted delivery, cesarean sections and so on and so forth. If the delivery has any problem, the card also covers the 12 weeks after that delivery. And of course, in running those programs, we've seen a markedly drop in the number of pregnant women that are dying. Because now it's free. People are even now running and looking, going to our places and asking, is the video of walking here? And of course, it can't also take care of all the pregnant women in Ogun State. Because funds.
Yeah. Yeah, well, let's look at because information, they say is power, really, and for things like this to also be very, very, effective, really, and then to be acceptable, widely accepted. Information has to trickle down to the nooks and crannies of the state, to the rural area, hinterlands, and the rest of them. So how, aside TV programs like this, platforms like this, where you have the opportunity of talking, to the people about this, what other measures, have you been employing in pushing?
Are we talking about the vulnerable schemes, or we're talking about all the schemes?
All the schemes.
Okay. Because you see, what we do for both or for the three are different. I was good. The formal sector scheme presently is for Ogun State workers. So there are channels of communication. Yeah. So we don't really need that much advice. Sometimes we leverage on the Ministry of Information. They are very, very helpful. They give us the advance, and we go around the parastatals and start our messages of what we want workers to do concerning insurance of your study. If I take something like Kidgero, we also don't want their jingles, we play those jingles. We also don't want, assuming His Excellency, there was a time he gave us funds to enroll about 50,000 pregnant women. If we go on air, all the 50,000 will come out in the next day, even though they are not poor. So sometimes we leverage on community structures. So what we do for programs like that is that we go to those places during booking. We have tools that once we have started some of these questions, I don't want to explain this too much. But when the question says you have what kind of phone you use, and you tell me you are using iPhone 17 or 16, you can't be poor, Abby. So we administer those questionnaires, and we pick those people that want to enroll and enroll them. We don't really need too much advice. We have another one, basic healthcare provision fund, that is much bigger. We leverage on the CDA structures. So we tell the CDA chairman, please identify, we are breaking it down. As we want to do, just an example, we want to do like 1,000 in the state. And we now want to do 500 per local government. And we break it down into the world. So we might go and tell the particular CDA chairman that we need the two poorest people in your city. And usually they will submit those names to us. Sometimes they work with Soko. So if you do not really need that advertisement, yes. We just go quietly, we do our work, we identify those people, we visit them at home. We did an exercise just recently in November, December. And when you get to the house, I'm sure when I get to the house, I will know you are not poor. When I get to the house, okay, and we enroll them, we give them those cards, we educate them, and we leave. But when I take maybe something like the informal sector, which forms about 60 to 70% of the people living in the state, of course, the issue of how we get people to know comes in. There was a time we had a brand ambassador, Odelade, and we do roadshows. We know. Yes. There was when we were running a radio and TV program here, we had about 2 or 3 stations also running. So sometimes when we get funds, we do these things. There are times we do jingles. That is one of the opportunities. When somebody come and say, I was so happy. I spoke about insurance. There are one of the people that will listen, and of course they will go out and ask questions the time that, okay, these people are really good. But of course, I will also agree with you that we've not done enough. We have balance. We have billboards in all the 4 political zones in the state, strategically positioned. Maybe as they are entering Shagam, as they are going to Mowe, as they are entering the Lao, just at that junction. You understand? So we have all those kind of things that we've done.
Okay, I think that's one of your roadshows.
Exactly. And
Saturday sometimes, early last year.
And although like that I'm not promoting, but it is very, very, very wonderful. And those are my friends in the background.
That's the commissioner. Dr. Tommy Koka. Now, let's take a look at, some persons will say the quality. Okay, let's talk about the quality of services. The quality, yes, that one
in insurance or generally,
yes, generally,
they are not there. They are not there because we all know the problems. They are not there because we are all expecting government to do everything for us. But government has what I would call conflicting priorities. Government is expected to do the roads. Government is expected to provide water for everybody. Government is expected to provide health services for everybody.
And they should, really.
They should,
or they should not.
They should, but the economics also tell us that funds are always limited or scarce, so they can't do everything. No government anywhere in any period has been able to do that. So we also have to resort to helping ourselves. Insurance is one of the ways. For paying a premium, now let me give my normal analogy. Our premium is 12,000 naira per year, and we promise that we will do everything. We are doing everything that we should do. There are people that are paying 12,000 naira. They have our cards, their patencies, they are diabetic, they get their drugs every month. Those that are worth between 5 to 11, 12, 15,000, they get it, and they don't get to pay. Anything in addition extra. If they pay extra, because they want to pay. Oh, really? It's because somebody is expecting them. Because it should be free. Once you get the card, we have people that have our cards. They do cesarean sessions, they do magnetic, they do fibroid surgery, they do all those things. And how do we, or how are we achieving this? Assuming we have 7 million people in the visit, the 12,000 naira comes to 1,000 naira every month. Just assume that we are all health insurance compliant, as we say, and every month everybody just passes in front of my office, these 7 million people, and get their 1,000 naira and leave. Do you know how much that is in a month? 7 billion naira. The narrative will start changing. The infrastructure is dilapidated, will start changing it, because government is not touching our funds. I give kudos to this present administration. They are not. Let's talk about them. Our money is with us. The fact that I go to the facility area, I don't get the drugs I should get. We provide the drugs from the 7 million, in the 7 billion every month. Look at that money. Are you getting it? They are not paying us very well, and so on and so forth. There are the special allowances that we give people that want to work in the area and things like that from the 7 billion. And that's what we're doing now. Because insurance is all about creating a pool and then strategically purchasing services for people. And that's what we're doing. So for those in the informal sector that have trusted us with their money, then join it. 12,000 naira, that's what we ask for. Come and collect. But don't wait until you fall sick before you bring that 12,000 naira to us. It's not going to work. I don't know whether you get that.
I understand you.
Which is what people are doing. Some people are doing now. You now get somebody who has gone to a private hospital. They've not diagnosed that maybe, for example, needs prostate surgery. Because these are some of the cases you get a lot. Prostate surgery and CS. The man has registered in a private hospital. They now say, this particular pregnancy is going to end up at CS. They've given her the bill. But she now comes and wants to pay 12,000 naira and then get the CS done from us. It doesn't work. We have to. There are check and balances to make sure that.
In such situations, what do you do? I mean, so that people can hear from the horse's mouth.
The first thing now is that there's a waiting period, which is a principle of insurance. So you cannot come in today, collect your card today, and say you want to get the surgery done the next month or even the next 3 months. There's a system that monitors these things, and you will not get a code for that surgery.
Let's also, take a look at yes, is it for all the both the three you talked about the former group and the vulnerable group. The premium is 12 is 1,000.
You see, what we've done is till now we've tried to make sure that we don't put too much classes in the different groups, which causes stigmatization at the point of care. That is what the book says. So if you have there's a green card, there's a black card, there's a red card, you understand? So when you get to maybe the state hospital now, there's a tendency that people now want to attempt to maybe the platinum card or the diamond card first. So what we've done so far is that everybody is still on basic. We are having discussions of people that want top-ups, but so far we've not. So for the formal sector it's 12,000 naira. For the informal sector it's 12,000 naira. For the vulnerable group it's 12,000 naira. All the cards are the same, except for, well, we will know from the codes that are on those cards. But when you get to the point of care, there's no class of stigmatization for now.
The financial muscle of the person in the formal sector, or even the person in the informal sector, we cannot compare with that person who fall under the vulnerable group. How much of acceptance really have you seen from the vulnerable group?
One of the things that we've done that made them happy is the fact that when they get to our facility, nobody is looking at them as being the poor. Because just as I've told you, everybody is carrying the same card. So it's only the workers and those that are the consuls, the digitalization aspect of it, that means that these cards are different from one or the other. If not, it's the Oxia or yellow lemon green card that we give everybody. Because we also don't want that stigmatization to come in. Now, so the vulnerable group, they are expected to also pay 1,000. No, the vulnerable group gets somebody to pay for them.
Oh, get someone to pay for them.
So for a big or now, just as I said, the state government, His Excellency has paid for them.
Okay.
For basic healthcare provision fund, this is an intervention between federal and the state.
Okay.
So federal and the state has paid for them. So when we do those enrollments, just as I said, we just go to those communities and give them the cards. They are not paying.
They are not paying.
Somebody else has paid.
And of course, you get the information of that particular person probably from one of the...
Sometimes you use maybe the so-called list and things from those structures.
So that person that truly needs that care.
There are also philanthropists that pay for people. I know somebody at the Jebu side is still one of our best customers that paid for 1,000 people. So he also determines who we enroll. You understand? He will give us the list of those that we should enroll in this community. So all those ones also come in. So those ones might not really be poor, because he determines that okay, let's say everybody in my community, let's say everybody in my house, let's say everybody working for this company. We have cases like that.
Okay, so let's also take a look at some of the challenges that you are actually facing. Probably we should not be talking about that, but let's talk about it, particularly when it comes to relating with the people. So that
let me group the challenges into three.
Okay.
The challenges from our clients, the challenges from the health workers, and maybe our own challenges, because we are not perfect. So from the clients, the major challenge is that the expectations of our people are so high when they are now also making use of this card. Somebody goes into the facility, instead of telling the doctor what your problem is, they're already demanding for one thing or the other. Doctor, I want to do tests. No, you're not the one that should tell the doctor that wants to do tests. Or doctor, I want to do drugs. So they get angry. So they're not being treated fairly. No. When you get there and you meet a nurse or you meet a networker, your duty is to say, I have fever, I have a headache, I cannot sleep, and they give you the drugs. Sometimes because of abuse of drugs, self-medications, and people recognize all these drugs. That's the second level of challenge. And you know, and when I got there, they just give me 3 drugs alone. There's this one and this one and this one, because they understand all these drugs. They want branded drugs. But that does not mean the generic drugs does not work. Insurance does not be branded anywhere in the world. Quotes me. And what I mean by branded drugs, I don't want to promote any drug, but I think I can still say this. You get there, they give you paracetamol, you are demanding for Panadol.
Okay.
So that's an example. There are others like that. The paracetamol will work. It has not that number. There are check and balances. There's a drug management agency that check and make sure that these drugs are okay before it gets into our facility. You have to collect it and go and use it and come back if it does not work. But now see people asking for specific antibiotics, and this common one, Bicham anti-clock. That one I'm not promoting. we want, and they call and start complaining. So that's from patient side. Of course, patients also trying to blame us. They already know they need surgery before they come and enroll, and they now start shouting, after I got the card, they didn't do the surgery. Sometimes some of these surgery costs as much as 1.5 to 2 million. So you can imagine somebody coming to collect. You have an online platform where you can even enroll. So they enroll, they collect the card, and 2 months later they will now start making us in the office. Sometimes old orthopedic cases have been there for 8 years. And they now start saying, no, you must do it. There's also problems and so on and so forth. So that's for patients. Some of our health workers are not helping matters. But let me make a case for them. They overwork. But some of them just don't want the insurance to work. Because they prefer people that come to pay. They just don't understand the principles of insurance, that we pay that money to somewhere up front, or we're going to pay afterwards to a particular management account. So they don't want the insurance to work. What's our challenge? They are short staffed. We can't do everywhere. We have agents that are working for us, but they are not the up and doing. But we go to work every day without enthusiasm of making things better for every day in the health insurance ecosystem.
Are there times where you get reports that probably those roles in the insurance scheme, they get to some of your health facilities, and then probably they are not every day they are not given the right not the right treatment, probably the attention, attitude, that those who come to pay actually enjoy.
Now let me tell you why I said every day. We have a 24-hour hotline. At the back of our card there are 2 hotlines there. So we actually encourage people to call us to make a noise if they don't get the attention that they want. And the switch line is there, 24 hours. Call it in the middle of the night, somebody picks it up.
So what has the agency been able to do to address that?
There's a quality assurance team that addresses all these complaints. The complaints do not get taken off the system until it is addressed and resolved.
Yes.
We have a task force also separate that collates and visits most of those places where these things happen. Let me give an example. The system realized in the course of 1 month that a particular Dominic PhD, there have been 2 or 3 complaints from that Dominic PhD. Definitely at the end of the month, Dominic PhD gets a visit from us. And not just a visit. We do a lot of strategies. One of the first things we do is what we call the mystery client strategy. We will give somebody a card who is not sick. They will go with a team. The team stays at the end of the road or street. The mystery client goes into that facility and demands for treatment. When he or she finishes, he calls and the team comes there and they explain what has happened. And usually, the complaints that made us to go to that facility will still be shown to that mystery client. Assuming that the facility has not been giving them drugs, they still will not give that person drug. Assuming the facility is used to keeping them waiting unnecessarily, they will keep the person waiting unnecessarily.
Sure.
So it's not a case of, no, they're lying, we don't do it. The evidence is there.
Yeah.
And usually, of course, when we give them that first visit, they sit up. They don't want us to pay another visit and so on. But you see, most of these things funds availability of people and so on and so forth also. But there are no ways that to get 3 strikes on our switchboard that the team will not visit that facility. No way.
The program Stay Focused live right here on OGTV, the People's Daily, and they have actually been evaluating the Ogun Health Insurance Program. How effective really has it been, its coverage and its acceptability, and of course the impact it has actually been making in ensuring that health, which they say is wealth, people can have access to quality health care and of course at affordable rates. We go on this quick break. When we come back, the program will continue. Do not go anywhere.
Attention please, this is to notify the people of Ogun State that Ogun State Ambulance and Emergency Services, officers under the Ogun State Ministry of Health, in collaboration with the federal government, NEMSA, is running a groundbreaking free ambulance services in our towns and villages in the all of the 20 local government areas. Just call 0811-200-0033 whether it is pregnancy emergency, labor, or urgent care for our little ones under 5 years that are experiencing diarrhea and convulsion. Help is just a call away. And that is not all. Accidents on the road or major emergencies at home or work are covered too. What's more, you will also be treated free of charge in the first 3 days, which is 48 hours of admission. For free ambulance services, simply dial 0811-200-0033. Let's come together to prevent death from emergencies and save the lives of our mothers and children. Great people of Ogun State, this safety is our priority. Spread the word and let's make a difference. This announcement is brought to you by the Ogun State Emergency Medical Services and Ambulance System, FMSAS, of the State Ministry of Health. Once again, save this emergency and ambulance number 0811-200-0033.
Of course, the program is still focused live right here on OGTV. The People's Daily. Glad to have you join us again. Yes, we are actually evaluating the Ogun Health Insurance Program. Yes, and we still have in the studio with us Dr. Afolabi Dosobo, who is the Executive Secretary of the Ogun State Health Insurance Agency. Don't forget you can also be part of the conversation. The number for you to call will be placed on the screen. Feel free to call us and let us have your thoughts, really. Probably you also have first-hand experience with the staff of one of the health facilities in the state as someone who has enrolled in the health insurance program. You can also share your experience so that we can learn, and so that the executive secretary can also address it. And if you are that person who, you're just planning or just contemplating on joining, you can also ask whatever question you want to ask, so that you can also provide answers to them, for purpose of clarity. Let us take a look at partnership, really, that you have been able to get in ensuring that this is a huge success. How much of it really have you been able to get? You said it, government cannot do it alone, and then you also pointed out that yes, some individuals have actually also been doing one or two things. But again, what other partnerships or areas of support have you really been getting?
Let me start from the fact that the federal government has been supporting.
Okay, federal government.
Because they also have an initiative that they are running, which is also it's usually for indigent people. There is one for the poor people. There is one for people that have fit solar in the country, and we get those. There is one for, they also have any emergency cases that enter any of their own tertiary institutions. After treatment, they send them to us to enroll for them. So there's a partnership with government, with the federal government, through the NHIA, National Health Insurance Authority Gateway. So we have that strong partnership. The laws that also set up NHIA and NOXIA also enforces that partnership.
Okay.
Because there are things that should come from them that comes to us. Most of the other partners that we have are people that want to work with us that I will prefer to call clients. So if somebody comes and wants to enroll 1,000 people, it's more of a client, but it's also helping us. We have people, fintechs and so on and so on that are coming and want to do one or two things with us, but it has not seen the light of day. So I think I'll stop there.
So as executive secretary, really, of this agency, what would you say is that milestone that you've been able to hit?
before we had the agency, there was the department. Before the department, there was a unit. And that unit ran a popular program in the past, a popular community-based health insurance program in the past. And it was that unit that now changed into a department. And it was that department that changed into an agency. And at every point in time, there was this target that in social period we should be a department, in social period we should be an agency. Because all those things come with definite activities that we need to take. To become an agency, we have to pass, develop a bill, take it to the House, make sure it is passed, and assented to by His Excellency. And then there are the civil service activities that need to go around in setting up an agency. But after that agency was set, we had this strategic document where we gave ourselves the target of the number of people that we need to enroll every year. I can tell you that we met the second and third year. That was at 2%. We met that. I think we met 5%, but we are lagging behind now. Because for this year, I think we should be at 10%, and we've not reached 10%.
Where are you now at the moment? You want to tell us?
We are, even according to national, we are at 7%.
Okay.
So the documents are there.
That's not far. It's not far from getting.
I'm not so happy. I would have wished that I could continue saying, even at this year we've met at 10% and so on and so forth. But it's becoming increasingly more difficult to convince people to do the insurance. The only good thing is the fact that those spending out of pockets are now realizing that it's not an easy thing to do. Insurance is better. Why are you going to a facility and spending about 15,000-20,000 for malaria when we can treat it for free once you have that card? The popular typhoid everybody is treating every month. Why are you going there and spending 10,000 to treat typhoid every month when you can get the card for 12,000 for a year and it covers every other thing?
Just having fun. So also in insurance, the more the merrier. I mean, the more.
That's what it means. Yeah. It's a game of arithmetic.
Yes.
It's a game of numbers. It's of course the more pool we can create, the more people we can take care of every day when they fall sick. It's simple. If I get 1 million people today, now that's 1 billion naira that comes in every month. So if somebody now comes and say they need an operation of 1 million naira, I'm more likely to do that operation. Now if I have 10,000 people and all I have in the account is maybe 100,000, you understand? So of course the more the merrier.
The number for you to call is still there. Feel free to call us and let's have your thoughts or your questions really. So yes, the more the merrier. What do you have any plans really in place to see that all of these people who are still outside the scheme are captured?
That's what we do every day. There are basically two things that we do in the office every day. Those that are trying to capture the uncaptured, and those that are making sure the capture gets quality services. So you are either one of those two. Of course, we are not resting on our hours. We write associations, we visit associations. In fact, we are having a meeting on Thursday with some of these CDA structures.
Okay.
So we are still doing all these things. And for everything we do, some people come in. I don't want to mention the numbers, there are more than 20,000-30,000 CDAs in Ogun State. So when we meet them at different levels, which we are, there's a new executive structure in place now. For those that know, those that are hearing, they know what I'm saying. At the CDA level that came in June, July, August last year.
Yes.
And they've not finished at the state level. So we're going to start meeting all of them at different levels. Imagine if these 20,000 CDs, for example, give me 10 people each.
Just 10. That's
100,000.
That's just you just 10 from them.
So once we meet and say, please just give me 10 people in your CD that can afford it in the 12,000, and let them start with us. It is the ripple effect of what they gain that will bring others. So those are some of the meetings we do. To leverage, we visited NATA. I think NATA was as long as the union body will be settled last. And they said, okay, let's compile the names and we'll come back. Because we told them, somebody carrying the engine and the engine falls and crushes his leg, who treats that person? And it is, in fact, they basically do not believe us. These people's matter are sweet and things like that. It was just 12,000 naira. It's okay, let's try us. So those are, of course, they are not resting. They are not just sitting in the office.
Now let's take a look at. I mean, this is an agency of government, really, and one would actually. I mean, one knows that anything government, there is bureaucracy, there is bottlenecks, and the rest of them. But we know health is an essential service, really, and so when it comes to bureaucracy, that should not really, have effect as a matter of fact. So. Are you also ensuring that the bureaucracy associated with government, civil service and the rest of them is not really having so much of effect or saying in your operations?
Let me say loud and clear. I'm not a politician and I'm not canvassing. The Prince Dapadrodun administration has never meddled in our funds. Insurance, and just as we have auction in Ogun State, we also have an agency in all the 36 states and FCT. And there's been some form of standardization on the operations. Okay. Majority of our funds is even sitting with CBN. I can say that. Majority of our funds is in CBN. So if you, for people thinking, we have a law that sets it up. We have a legal framework, and we are semi-independent of some of those things that you are thinking of, you're asking around. So we are not going to wake up one and say, this person needs 100,000 for surgery, but you cannot do it yet because government has not released that money. It doesn't work that way. The funds is in CBN and we can pay directly. Of course, there are agencies that also oversight our functions and make sure that it's not that we are totally out there, but they don't affect that day-to-day operations that affect our carrying out our commanding.
I used to have a friend who actually enrolled in the, I think it's in the formal sector.
So he's a civil servant.
Yes, a civil servant, and then he was bragging that, I want to get the glasses now. I'm going to go to the hospital and get it.
And he didn't get it.
And he didn't get it. He was so disappointed, as a matter of fact. And then
I hope your friend,
he was praising you to the high heavens, before he went to the facility. But
I hope it's only the glasses that he has been disappointed.
Yes, just that.
Now, let me, for civil servants, he shouldn't have been disappointed. Because when we were only civil servants, we also made a flyer that says that there are total exclusions that you are not going to get. And the total exclusions, there are 5 of them that cut across all schemes, irrespective of how you come in. We don't do brain surgery. We don't do liver diseases. We don't do kidney diseases, we don't do secondary fertility, and we don't do cancer. I hope you get that. But let me clarify the cancer. The early onset stages, we help. The woman comes with a breast lump, we remove the breast lump. You present early, we'll still help. But once the diagnosis of cancer has been made, the funds are, we don't do that. For the cases of glasses, 2-3 years ago, he probably would have gotten his glass. But you know what we noticed? We now noticed that immediately somebody is enrolled and gets his card. Even when that person has a glass that he or she is already using, they go the next week and collect another glass. Now, look at the mathematics. We were paying 17,500 for those glasses that they were getting free. So somebody gives us 12,000 today, Wednesday. On Monday, Tuesday. Monday next week, we will collect a glass worth 17,500. And it still has a card to use for 1 year. So it wasn't sustainable. We now asked to get approval to stop it when people started getting 2 glasses per month. I'm serious. The statistics are there. So somebody goes and says, I just paid we accosted someone and they said, I decided to get one extra as backup. So you are paying, they look at civil servants, it's tied to their salary. They're paying 500 naira every month. The excellencies are subsidizing. So once we remove, it's a sense of entitlement that Africans have. It's called moral hazard. They started removing my money, I must enjoy this thing to the fullest. Sometimes you see people that are not sick going to the hospital because they just feel this month have not been there. So it happens.
Now, you medical doctors, you advocate for regular health screening. You know, particularly when one has attained 40, you know, and above. Now, all of those things that one should be checking, you know, periodically, are they also captured in your health?
That comprehensive medical screening that people want, it's not captured. But the basic ones that you need to do is captured. In fact, let me make an announcement. Because the Honorable Commissioner for Health, Dr. Tomoko, has given us approval for it. We are very soon, in the next 1 to 3 weeks, going to screen all civil servants, all female civil servants for breast cancer.
All female civil servants?
For breast cancer, or those are willing to be screened.
Wow. Because
our statistics shows that 60% of those that are presenting with us are becoming positive for cancer.
Wow.
So those are some of the things insurance does.
Men also have a prostate. Are you doing anything about it?
Once the statistics comes that there's a problem there, we will do something to it. So people should just watch out. We are discussing presently with organizations that can treat those that are positive. But we'll soon roll it out, and I'm sure you'll hear about it.
Now, let's get your final thoughts really as we coast home, really, particularly to residents of Ogun State who are actually, you know, not yet captured within, you know, the insurance net, or that are skeptical, as a matter of fact, as to the quality and the rest of them. What's your direct message to them?
Very simple.
And how can they easily enroll today?
Very simple. You've mentioned it in your introduction. Out-of-pocket expenditure is no longer sustainable. We're asking them to just process the 1,000 naira per. I'm picking my words carefully. Just 1,000 naira per month, and the 1,000 naira is just 2 pet coke. So they should forgo 2 pet coke in a month. Give it to us, and then let us work together. The challenges that they meet on the way, will be solving it. Because the more the merrier, the better for them. The other aspect is for those that are skeptical. Please join us and then make complaints. Is those complaints? We put in a lot of mechanisms for your complaints. Is those complaints that will add value and color and make the program even better for every one of us. It's not when you sit outside. It's easy to sit outside and criticize and say this and say that. Join us.
And then the last lap of the question,
which is,
how can one?
Thank you. I can make a statement of fact that they should just search for us on any of the social media, Facebook, Instagram, X, whichever one, TikTok. We are there. Our contact details are there. But I would say that they can call any of our hotlines. The ones I can tell them now is 081111 460
Can you take that again?
081111 60404. Once they call that line, any time of the day, any time of the night, they can ask for where our agents are. They can even come home to come and enroll them. We have 40 agents scattered all over the clinics of the local governments of the Ogun State. So,
Dr. Folabi Dosumu, we must thank you for your time with us this afternoon.
Thank you for having me.
Take a look. Yes, it's our pleasure, really. He is the Executive Secretary of the Ogun Health Insurance Agency. Thank you so much. And of course, we also thank you so much, our viewer, for watching the program. Thank you for keeping faith with us right here By God's grace, we are going to be back next week with another edition of the program. I remain Dominic Agbea. Enjoy the rest of your week.